Hello, everyone. It's Steve with Magnolia Pharmacy. We will get started in about 30 seconds. All right, let's get started. I'm Steve Hoffart with Magnolia Pharmacy, and today I've got a really special guest talking to me, and we're going to talk about a women's health issue that I see at the pharmacy all the time, and that's menopausal women and perimenopausal women that come in low in iron and low vitamin D, and I don't think people realize what that ultimately means to their health. So today I'm joined by a P4 pharmacy student from the University of Texas, and I am going to let her introduce herself.
Hi, everybody. I'm Kimberly Cuellar. I am a P4, like Steve said, from UT Austin College of Pharmacy. I'm currently doing my community rotation here with Magnolia Pharmacy. They're a wonderful team, so we're definitely excited to talk to you guys, answer any questions you have. I know deficiency in vitamin D and iron can be very popular, so we're definitely here to help guide you on any confusion or questions you might have.
Very cool. So once again, like I said, in clinical practice, I see this all the time. Women who are in perimenopause and menopause, they almost invariably, the ones that do the worst are low in vitamin D and low in iron. And they just go synonymous. And a lot of times you don't see women with just one or the other. So what I want to stress as we go through this, whether you're on Instagram, whether you're on Facebook, or whether you're on YouTube, what I want you to do is drop your questions in the chat. We will do our best to answer as many as we can. We're going to go about 30 minutes here. Once again, we're not here to diagnose or cure any clinical diseases or stuff. We're just here to give you information so you can make good decisions about your health. So what I want to do is, once again, if you'll drop your questions in there regarding that, we'll be more than glad to answer those. So please make sure you're doing those throughout the time we're on. So just as a start, looking at, once again, and I think this is what's key, there's a lot of ladies who have menopausal symptoms or perimenopausal symptoms. And that's a hormone thing. We get that. I know that. I've worked with thousands of women with hormones. But let's start out with, if a woman is low in iron, Kim, what do you think are the most common things she's going to notice related to being low in iron?
Yeah, so some symptoms of iron deficiency can be like fatigue. So some women can feel like winded or dizzy or exhausted just from doing simple movements. Also, tissue, some symptoms like with your tissue, so maybe like nail health, hair shedding, or cracked lips is also symptoms that can happen. And I guess there's also symptoms with legs, so maybe intense urge to move legs at night, which is called restless leg syndrome. That can also happen from iron deficiency, but mainly women can just describe it as brain fog. That's just a really common way to explain iron deficiency, and that's the most common symptom from it, I would say.
So you mentioned aches and pains, like muscle aches and pains related to low iron, low blood flow. You mentioned hair and nail issues. You mentioned, I mean, I could tell you, when you're low in iron, you may not be quote unquote anemic, but you don't carry oxygen and nutrients to the tissues like you're supposed to. So you feel run down, tired, fatigued, which are all the same symptoms a woman will deal with during perimenopause and menopause. So unless you're checking this real closely, doing a rotation right now, Kim Cuellar, she's from the University of Texas, and we're talking about something that we see a lot at the pharmacy, and that's women who are low in iron and low vitamin D, but especially during perimenopause and menopause. I want you to drop your questions on the comment. I see some comments already being dropped in here. I think
5-hydroxyvitamin D test. So you can let your doctor know of that. It is a separate blood test, so you're not necessarily going to see it on a basic metabolic panel or a CBC panel. So that's definitely important to ask for if you're wanting to know your vitamin D levels. And then for iron, you would want to know what your ferritin levels are. So I know a few of you guys are commenting about that, but that is your full iron panel that your doctor can also read through your blood. And then that would definitely confirm if you are lacking iron in your body.
Got it. And that's a great call out. And let's take a little deeper dive in that. Just so people know, when you take vitamin D, we don't actually check the vitamin level of the vitamin D you took. We look at that 2,5-hydroxy, which is the activated form of vitamin D. And what's important to remember we'll get a little bit of that, certain vitamin D supplementation is better to make the active form than not. I want to bring up, as a pharmacist, this is not, once again, my recommendation based upon the literature and data. Even though normal may be as low as 30, I like to see ranges more like 50, 60, 70. But one of the things, so that's the one thing about the iron, the vitamin D. That one's relatively simple. The only other thing I would say, along with checking vitamin D, you want to check something called your RBC magnesium, which is a magnesium status within your blood cells, because you have to have active magnesium or enough magnesium to activate your vitamin D. So that's super important. Kim mentioned ferritin. Ferritin is a storage form of iron. It's one of those forms of iron, how your body stores it. But you also can look at total iron binding capacity. But in addition, they're going to look at things like anemia. They're going to look at your red blood cells. They also may look at your B12 levels and folate, because those also go together to create your red blood cells. And the sad thing is that if you dose some of these and don't make sure of adequate levels of all of them, they can actually mask each other in that anemia case. But I would say the one thing that's been asked a lot of times is ferritin, and I would agree, because this plays a big role in terms of helping with things. Even though a normal ferritin could be down like in the 20s and 30s, I will tell you, for women to be optimal that I see working with, we like to shoot for ferritins in about that 100 range. And I'll tell you, not only for you're making your red blood cells, but you also need adequate ferritin levels for your body to convert your inactive T4 to your active T3, which can then further cause things with further fatigue, tiredness, anxiety, and things like that. So while we're talking about blood levels, let me see. I answered the question about what should your ideal iron. Once again, we're talking about women in menopause, low vitamin D, low iron, what that means, what it looks like, how to fix it, what are the causes. So that's that part. Drop your questions in the comments. Once again, we're going to do our best to answer those. We got some great questions coming on. There's a lot of you coming on. One of the things was talking about Epstein-Barr causing low ferritin. Well, one of the things that can cause low ferritin, this is really interesting, is stress and inflammation. And I know, Kim, you and I talked about that a little bit. What does the body do when it's stressed and inflamed? Why would it make your iron level low? Do you remember what we talked about a little bit earlier?
Yeah. So chronic inflammation is also very common in menopause, just because your estrogen's dropping. And that when that happens, you release hepcidin. And whether you're going through menopause or not, that happens just from stress as well. Stress is super common in our everyday lives, if we're being honest. And once hepcidin is released, that blocks iron absorption. So that's what we don't want for our bodies to properly work. So as far as chronic inflammation, it's just a common reason as to just a root cause of iron deficiency, specifically because it blocks that production.
I liked how you talked about the hepcidin. So just to reiterate what she said, and so everybody understands, when you have inflammation, and once again, that can be caused by strep and underlying infection, because one of the people asked on here, Epstein-Barr virus, that's an infection that actually drives inflammation, makes the immune system go out of whack. In addition, if you've got low vitamin D, that makes it even harder for your immune system to react. But if your inflammation is high, your body makes more of something called hepcidin, which will actually prevent your body from absorbing and storing as much iron. So it's this thing where, and I see this with so many women, they're even eating good diets of iron, they're taking iron supplements, but they don't get the benefit. And that is exactly a good call out on that. And that's one of the mechanisms why that happens. So that's a really great call out, because that was one of the questions on here about Epstein-Barr causing that. Let me look at more of the questions that we have going in here. I see somebody talking about vitamin D in the sun. One of the things I will tell you, I recently did a podcast on vitamin D, and I will tell you there are so many things that affect your vitamin D status. And those are things can be like your age, it can be your race, It can be the color of your skin. It could be where you're at on the equator. There are so many different things. Like I mentioned earlier, magnesium status. All of those things can affect your vitamin D. So even though you're out in the sun, you still need to be checking those vitamin D levels. And if you're supplementing, you need to be checking your vitamin D levels. I actually recommend twice a year, but that's also important in terms of making sure you have adequate vitamin D. We haven't talked about supplementing, but let's talk about that for a second, Kim. If you're going to supplement with vitamin D, if you have your choice between D3, which is technically speaking an over-the-counter product, and D2, what information do you have about that in terms of maybe which one may be more preferable versus the other?
Yeah, no, that's a great question. So yeah, like Steve said, there's two types of vitamin D. So there's vitamin D2, vitamin D3. D2 happens to be really commonly prescribed. So we're seeing it in the pharmacy constantly. And this is what prescribers are prescribing to their patients to fix their vitamin D deficiency. However, I think it's really important for you all to also know about vitamin D3. So this one is over the counter, and I would say it's much more identical to how vitamin D is made from your skin from sunlight, which is great. We want that. And it's over the counter, it's soft gels, and overall, it's a higher potency than vitamin D2. So it stays in the bloodstream longer, it sustains your vitamin D levels longer. So that's great. And that's another option aside from the prescribed D2 that physicians are commonly prescribing. D3 would be more of a maintenance dose, and it can be used to also fix, it can replenish if you're severely deficient as well.
I like that you brought that up, and that's the truth. As pharmacists, we get prescriptions a lot of times for D2, and I'm not saying it's wrong. That's what I was taught in pharmacy school. But what we're learning about vitamin D, that D3 form is definitely converted more easily into the active 2,4-hydroxy vitamin D. So that is one advantage. The other thing I'll tell you about the prescription vitamin D product versus the over-the-counter vitamin D product, most of your vitamin D products now are doing and are basically combining vitamin K with it. Because one of the issues that happens with low vitamin D is, especially with perimenopausal and menopausal women, is bone loss. And especially early on in menopause, when 25 to 30% of your bone loss happens those first couple of years when estrogen drops, you want to make is if you do, you can have an impact, because D actually helps your body better pull the calcium from your diet and from your gut. It's the K that moves it in the right direction. And we want to move the calcium not into our vessels, which could potentially increase cardiovascular risk, but we want to move it to our bones to help build stronger bone. So that is super important in terms of understanding that. I'm getting a lot of questions, so we're going to kind of jump into a few questions real quick before we go any further. One of the things I did want to bring up, we talked about inflammation and ferritin. So several questions here about ideal ferritins, how much ferritin should I be on? And I would agree, like I mentioned earlier, ideally want to shoot for a ferritin around 100. But what I do want to say with that is you have to be careful. If you only check ferritin and you don't check something like HSCRP, which is a marker of inflammation, you might miss this. And here's why. And I'll do my best to explain it. When your body is inflamed, it actually will take and use ferritin as a storage form of iron, and your ferritin levels can go up way higher than they should be. But what happens is if you're inflamed and your ferritin levels don't jump up, that probably means when you started, your ferritin levels were super low. So if you're looking at your HSCRP, which is a marker of inflammation, and you're not looking at that ferritin at the same time, you might miss actually a low ferritin because the HSCRP is driving the ferritin to be higher than it should. I know that's a little confusing, but I just want to stress you can't look at these markers in isolation. You've got to look at them as a sequence, how they all work together. All right, so I'm going to go down some of these questions because I've got a bunch of them popping in here. Let's see here. My information level is, what if it says my iron level? It says information level is really high. What's best? I'm not sure what that means. I can't skip that one. I see what it says. I said, I have a thalassemia trait. What can I take? I'm in perimenopause, 53 years old. And just so you know, regarding thalassemia, that is a genetic disorder, or people don't make the red blood cells quite the same. I would say for this patient, it is uber critical to make sure that they have adequate iron stores, ferritin, total iron bonding globulin capacity, adequate B12 and folate, because those are super important there. What should your ferritin numbers be at 60-year-old woman? My ideal, I like to shoot for around 100 if we can. Doctors don't like to give tests that are necessary for the whole picture. Dragon, I kind of agree. That one's kind of a frustrating one, but I always tell people you're your quarterback of your own dynasty and your own quarterback of your health. And so if that's the case, I think you have to find practitioners that are willing to work with you, or go find another one. That's what I would say. Oh, and we got a really nice mean comment, but I won't read that one because that one's bad. Let me try to see some more questions here. It says low ferritin can cause severe anxiety and panic too. What are your thoughts on that, Kim? I've got a back end thought on that one, but I want to get your thoughts. What are your thoughts about ferritin causing severe anxiety and panic attacks? What are your thoughts there?
That's a good question. Let me see here. Trying to think. I think it can trigger anxiety in specific ways. I think when you have like lower, trying to gather my thoughts here.
I'll give you my quick thoughts in this, and then you can see if you agree or disagree. So, okay. First of all, when you have low iron, you may not be quote unquote true anemic, but you're going to have less red blood cells than what you need. They're not going to carry oxygen or nutrients. And obviously one of the things that can affect is your brain. Like that's a no-brainer, right? If your brain's not getting enough oxygen. But the other thing we see with a lot of these same women at the same time, they're also low in B12 and folate and a lot of their B vitamins. Go into pharmacy school. I'm going to test you. Are B vitamins necessary for your body to properly make its neurotransmitters?
Yes.
100%. So I kind of wonder in the terms of the person that's low in iron, low ferritin, if they also probably at the same time aren't low in their B vitamins to make their neurotransmitters, they're not getting enough blood oxygen to the brain. And in this same lady, if she's low in vitamin D, can low vitamin D affect mood?
Yeah. I think your brain can perceive that like lack of energy as like panic mode.
Yep. And low vitamin D can definitely have an effect on depression and anxiety and all that kind of stuff. And that's the thing that I kind of wanted to bring up today about this is that I think a lot of the things that are going on in terms of the ability of someone to monitor these things is a lot of times we see these things together. And I think that's where the real challenge comes in trying to make sure people are taken care of. I'm going to jump over to some Facebook questions. Hold on just a second because there's some here. I have Lyme's disease and Epstein-Barr. Should I be taking more D with K2? You got a thought on that one, Kim?
I mean, well, K2 is definitely something that we recommend
right?
When taking vitamin D.
Let me ask you this. Do you think adequate vitamin D levels are needed, ideal? And I'm talking about optimal vitamin D. I'm not talking about the 20s and 30s. I'm talking about 40, 50, 60 to regulate your immune system.
Yeah. And then with just the Epstein-Barr virus, that's just going to trigger inflammation all throughout your body too. So we want vitamin D to boost our immune system, but the calcium can go to arteries, which we don't want. We want them to go towards improving our joint pain, improving our inflamed tissues, improving that brain fog that can happen. So with that, K2 can definitely protect against it. I like to think of K2 as like the traffic cop. And it's like you can have all this vitamin D, but it needs to be led somewhere good. So K2, I feel like, can be like that traffic cop that directs it to your bones and joints rather than your arteries, which can just cause separate problems that none of us want.
No, that's a great analogy. I love the traffic cop with the K. And like I said, I don't think you have to take extra vitamin D. I just think you need optimal levels, and that's shooting for that 50, 60, 70 range. I think if you go there, you're going to put your vitamin D in an ideal place where it should be. One of the things too was mentioned here about optimal levels. I think other than just checking ferritin, total iron binding capacity, vitamin D, You do need to check a B12 level. And ideally, I like to shoot for the higher end of normal for B12. That's important because that's needed to help also prevent anemia, but also your folate levels. I think that's also super important in terms of the folate. And once again, with all of these things, whether it be the RBC magnesium folate, I recommend higher ends of normals on those because once again, normal, that includes healthy and non-healthy people. I'm more in terms of being optimal looking at that. Let's see here. It says, I use vitamin D3 and K2 dosage of 10,000. Is that enough? I get this all the time. How much vitamin D should I take? We talked about this before. What's a general rule of thumb if you're wanting to start taking vitamin D? What do you think is kind of a good rule of thumb to take in terms of a dose to start? May not be your ideal dose, but a dose to start.
Yeah, so for vitamin D, we've talked about 1,000 units per every 25 pounds of body weight. So for the most part, that can leave us with about a daily dose of 4 to 5 to 6,000 for the daily dose. So that's kind of a general rule of thumb that I've learned here, at least on my rotation with Magnolia.
Yeah, no. So, and that's exactly right. So, what I want to say about that is, and I get this all the time, and you can go watch my podcast on vitamin D where I go take a deep dive. There's no exact science of this. Everybody is so different on their vitamin D. But what I do want to say is if you test and you're low and you've got to pick somewhere, I think that 1,000 units per 25 pounds of ideal body weight is a good place to start. Most people fall in that 4 to 6,000 units. But no matter what you're doing, if you're supplementing more than 400 units a day, which is like what the RDA is, which for most people is way too low, you need to be testing. Like people ask me all the time, how much should I take? Well, I don't know. Yeah. The thing is, and oral capsules may be great for you, but for some people, oral capsules don't work. And if that's the case, try a sublingual liquid. The thing is, work on yourself, get your dose to where you need to be, and then recheck yourself, like you said, at least annually. But if you're supplementing and you're not testing, that's where the problem is. It's like, once again, a doctor wouldn't just give you blood pressure medicine and then say, well, I think that's going to be a good enough dose and not check your blood pressure. Of course, they're going to do that. If you're going to supplement with vitamin D, we want optimal levels because we know that's where the most benefit is. We don't just give vitamin D and guess. You give vitamin D and you test when you're done. And I think that's an important thing for most people to know. I know I've been yakking for a while. You and I both have been talking. Just a reminder, anybody that's joining right now, my name is Steve Hoffart. I'm a pharmacist. I own Magnolia Pharmacy. I'm the host of the Trusted Pharmacist podcast. I've got a pharmacy student with me. Her name is Kim Cuellar from the University of Texas doing her P4 rotation. And what we're talking about is how common we see low iron and low vitamin D in women with menopause, but more importantly, what that means to your health. What are all the things that happen in terms of increased health risk, side effects, symptoms? We already know because I work with thousands of women how hard menopause and perimenopause is on women as it is. And low vitamin D and low iron just complicate the situation. So, and these are easily fixable things. They can easily be done. So drop your questions in the comments. I'll do my best to get to as many as possible. You guys are offering some great questions. So keep dropping them in the comments. So I'm going to go back and ask you a question, Kim. Let's talk about iron supplementation. We get this a lot. I don't know about you as a pharmacist. The most common thing I see is them writing a prescription for some ferrous sulfate once a day. Is there any data saying that maybe taking iron, maybe not every day, could be better than taking it every day, which sounds a little oxymoronic as a pharmacist to say that? Is there any data that maybe taking iron differently could be more beneficial?
Yes. So that's a good question. I actually wrote here on my notes about this because it's something that I also was educated on this year specifically. I honestly hadn't heard about alternate day dosing in terms of iron supplements, but there's sort of like this 24-hour trap that can happen if you are taking iron every day. So when you take your iron every day, your hepcidin can spike, and if that stays, that will stay elevated in your body for about 24 to 48 hours, which is great because that is what's keeping the iron inside of your body to be used and absorbed and, take away those deficiency symptoms. But if you're taking it every single day, then your intestines are really being overused there. And there just happens to be less absorption if you're taking it that close to each other. So overall, taking it every other day is what research says to be the best solution, just to allow your body to just absorb a higher percentage of iron for less amount of pills.
So I love that call out. And you got a point. If you've been taking iron every day and you aren't getting your levels up, you might consider switching to every other day. Obviously, talk to your doctor if they're the ones that put you on iron. But there's some data that shows you may get better absorption by taking it every other day versus every day. One of the things, too, I think that gets missed a lot about iron is the form of the iron you're taking. So quite often as a pharmacist, the most things we see, I see ferrous sulfate, I see ferrous gluconate, probably the two most common ones that I see a lot. What happens? Get your opinion. You're in pharmacy school, so here we go and test you. What are some common side effects when people take iron? What are some things they commonly see?
Yeah, no, that's a good question. So as far as iron, yeah, Steve mentioned there is quite a few, but I would say with those those few, some side effects that could happen is constipation. So maybe you have unabsorbed iron that's just sitting there in your intestines, and that can slow down bowel movements, which none of us want. Nausea can also happen too. Sometimes that happens because iron is best absorbed on an empty stomach, actually, but there are people where taking a pill on an empty stomach doesn't necessarily make you feel the best. So nausea can also happen from that. Cramping, also from just GI issues. Any upset stomach can also happen. So those are just a few side effects that happen just because your gut is reacting to trying to absorb iron.
I'm going to add a couple things to what you said. So first of all, you're exactly right. Iron GI upset is the most common. I'm sorry, constipation and GI upset are the most common things. But the sad thing is, it's because the iron you're taking does not get absorbed very well. And it's that iron station in your gastrointestinal tract and causes those side effects. That's why my preferential form of iron is something called iron bisglycinate. It doesn't have quite as much, quote unquote, elemental iron than ferrous sulfate per capsule or per tablet. But what you have to remember, it's not how much is in the capsule or tablet. It's actually how much gets absorbed. And what we find with iron bisglycinate is you actually get better absorption. So you have less GI distress, you have less GI issues, and you actually may get more iron in your body because an iron bisglycinate capsule only has like 25 to 30 milligrams of iron, where something like a ferrous sulfate tablet has 65. But the point is, if that 65 milligrams of iron, the absorption is only about 10%, and you get a 25 or 30% or 25 or 30 milligram iron product, and you get 60 or 70% absorption, you can do the math. You get a lot better. The other thing that's important here, we're telling women to take iron because they need it and they're anemic. But at the same time, if you're on hormones and your girls are having constipation, and so many women, especially during perimenopause, are already estrogen dominant, your body recirculates those estrogen metabolites, which further makes your estrogen dominance worse. So having regular bowel movements is so, so critical to make sure that you're maintaining your hormone levels and doing the things that you have to do. So we're getting kind of close to the end. We're going to go a few more minutes. I'm kind of going through questions. I've got a lot of them here. I don't know if we'll get to them all. Is there anything, you're the one that did a lot of prep for this, Kim. Is there anything we didn't cover that you're like, man, I've got to make sure menopausal and perimenopausal women find out about, because in research, I learned this myself. Anything else that you have to say about that?
That's a good question. I think there's like a really common, I guess, education point I want to make in terms of iron for sure. So iron, it's a mineral that's really easily binds to other compounds. So like Steve said, we can be taking a higher dose, but our body just might not be absorbing it to the best of its ability. And we want that, right? So some things that can affect iron absorption that can be quick fixes for us is making sure you're separating it by at least like a 90-minute to 2-hour window from like coffee. That's really common. Or dairy products or calcium supplements, any antacids like Tums. Those, when they are combined with iron, the iron just gets absorbed by that and not by your body, and we don't want that. So I guess just a really good educational point I want to make about that is taking it first thing in the morning is really recommended. You're on an empty stomach, your acid in your stomach's really high, which is the best way for iron to be absorbed. And then you're taking that before breakfast and before you do have the coffee. It can be a little hard if you take coffee first thing in the morning, right? Because that's normal for a lot of us, especially me. But you do want to separate that from your iron supplementation. So that was also just a really good point that I wanted to emphasize, because doing research on that, it's like that's a quick fix. Like, you might not be deficient because you're not supplementing enough. It just might be because you're taking it incorrectly, and there's other compounds like coffee, dairy, and calcium supplements that can just affect the absorption of that. So that was a point I wanted to share with you guys.
I like that call out on the iron. And I think you brought up a great point. That was actually one of the questions. Do we take iron on an empty stomach? And I would say yes, but that's why taking something like ferrous glycinate or bisglycinate is so important, because you're going to absorb that better and it's easier on the stomach than like a sulfate or gluconate. The other thing I want to stress is first thing in the morning is great. Like you just mentioned, can you name me one particular drug that a lot of people take in the morning that's also supposed to be on an empty stomach that should not be taken with iron? I'm going to test you here. Pharmacy school. What's that drug?
Metformin.
Got another one for you. What about this gland right here?
Oh, okay. Yes, you're totally right. Thyroid. So levothyroxine is a very common medication to take for thyroid, right? But that is one that you definitely want to separate from your iron supplementation, just because, again, it wouldn't be absorbed properly if you're taking them together. And that's just, a liver issue there. But definitely taking those separately is also really helpful. Yeah, that's a really good point.
No, that's a great one.
Yeah.
I had somebody else talking about they're having bone density issues and they're still taking their iron and their hormones and on. It says I'm taking calcium. I don't think it's getting absorbed. One thing talking about stomach acid that's important is the type of calcium that you're taking. If you're taking calcium carbonate, you have to have stomach acid for that to get absorbed. But if you've got low stomach acid issues, which happen as we age, or you're on PPIs or acid blockers, if you take calcium citrate, it does not require as much stomach acid to be absorbed. I've got a lot more other questions here. You and I both know we got a weight loss class today that I've got to do. I just want to thank you, Kim, for coming on. This is great information. A lot of women deal with this. I just want to talk about that if you want to learn more about women's health and a lot of these same topics, you can check out our social media page at magnoliapharmacy.com. You can also I have a podcast called The Trusted Pharmacist that we take a deep dive in a lot of these health topics. And honestly, Kim, I just want to tell you, thank you so much for joining me today. You had some great insights, great information for women, and really, really appreciate you doing that.
Yes, of course. It was really nice to be able to answer your questions. And maybe we can do this again another time. I'd be happy to.
That would be awesome. Thank you so much. Appreciate everybody joining us and hope you have an awesome day. Take care.